some of those questions and ask them.
Sorry.
That's
sorry.
okay.
It interrupts.
So, Liz, we're just going to let you kind of take it and go with it. She's going to share about herself, and then she has a PowerPoint presentation for us. I want to thank everyone that is joining us tonight, and I hope that you get the positive impact from what she's going to share with us that we have gotten, because she is actually my doctor and Gabrielle's doctor, and fixing to be my other daughter's doctor, so or PA. So we'll turn it over to you, and you've got the floor.
Okay. Welcome, everybody. My name is Elizabeth Scherrey. I'm actually a women's health nurse practitioner. What I'd like to talk about today is just based on what I've learned as becoming a nurse practitioner and how we recognize bleeding disorders, specifically von Willebrand's disease, in the OBGYN setting, and what we're noticing and what recommendations and guidelines are guiding our practice. So you can hit the next slide. So like I said, my name's Elizabeth Scherrey. I go by Liz, and I'm a nurse practitioner. I was trained in by Frontier Nursing University in Kentucky, and did most of my practice here in Arkansas and then in Northwest Arkansas. How I became aware, there's a couple different ways that I became aware of bleeding disorders. One in particular was when I was at a local health department and had a young woman come in. I'm thinking she was about 16. I can't remember if she was 16 or 17, but she came in with a long history of having heavy periods. And most of the time, what happens with young women, adolescents particularly, when they come in with a bleeding disorder, or not a bleeding disorder, but having heavy periods, is most practitioners and physicians will just automatically put them on birth control. And what we had learned in school was that no matter what the reason was for them to come in, we need to determine why are they having this bleeding, this heavy bleeding. And this particular young lady, when you started to do the medical history and the medical workup, you realized that very quickly that because of her family history, that there was a long line of women in her family that had bleeding, had postpartum bleeding, had heavy periods. And so then it triggers you to think about, why is this family particularly having all of this bleeding problems? Ended up this young lady did have von Willebrand, and went, I did follow her, and she was diagnosed and is being taken care of. I do not personally take care of her because she lives up in Northwest Arkansas. So, but that was one of the first things, was when I was doing some training. That was one of my first experiences. So I currently work at Women's Health, and I work with, it's myself, Amanda Spahn, who's a PA, and then our collaborating physician is Dr. Thomas Wood. And so I graduated in 2019. And so far, I have actually not diagnosed anyone with von Willebrand disease in my practice, but I take care of a couple of people that do have von Willebrand's. But try to stay up to date on different things. One of the things, you can change to the next slide. One of the things that I want people to understand is that what I put on this slide is that 1/3 of outpatient visits to gynecologists are for, it says AUB, which is abnormal uterine bleeding. And 70% of all the consults that we get in the perimenopausal and postmenopausal years are for abnormal uterine bleeding. 60% of those referrals were treated with hysterectomy. We're starting to change the culture And what's changing is that we are trying to find the underlying reasons why we're having abnormal uterine bleeding, leaning towards more medical treatment versus surgical treatment, and looking at understanding causes and treatment options to reduce hysterectomies. So next slide, please. When I went to school, which this is interesting because we talk about, this came out, this was actually designed by the Federation of International Gynecologists. It is, and it came out in 2009. It's how we classify abnormal uterine bleeding, how we look at it. And reasons behind it. So you can see on there where it talks about structural causes, and then it talks about non-structural causes. And you can look at the very first one is bleeding disorders. So this should always be in the mindset and in the forefront of any practitioner, especially women's health practitioners, that it can be a cause of abnormal uterine bleeding. So this came out, like I said, in 2009. Sometimes in our southern states, it takes us a little bit longer to start seeing this information and learning this information. And so this is where people that, like myself, that have recently graduated now come into the picture and know that this is the way that we look at someone that comes in with abnormal uterine bleeding. Next slide. When I was in, I think it was at the very end of my training, I went to a national certification program, and the national program was called Nurse Practitioners for Women's Health. And it was a week-long program, and we had a speaker, a well-renowned speaker that came up, and he talked about the top reasons for abnormal uterine bleeding in age groups. And so he broke it down into what we see at a certain age group. And really, we're looking at a lot of times adolescence, which is where, like I talked about earlier, typically adolescents come in, they're having heavy bleeding. And usually our thoughts are, well, they have what we call an immature HPO axis, which is just where the hypothalamus, pituitary gland, and ovaries are not mature enough to have a regular normal cycle. And so a lot of times we end up putting them on birth control to regulate their periods, and we've missed some of those young women that could have bleeding disorders. And so when you have someone that comes into the office, that's where we start looking at, instead of just throwing medications on them, looking at reasons why they're having that bleeding. Next slide, please. So one of the things that I have started at our practice is using a screening tool to identify adolescents specifically. Now I can use this for any woman, but specifically for adolescents, because those are the ones that usually will come in with that history of heavy bleeding. So the screening is just an 8-question, well, I guess it's 9-question because there's an 8 in the 8A. But a screening tool that recognizes how often they're having the bleeding, if they've ever had been treated for anemia, has anybody in the family ever been diagnosed with a bleeding disorder. These are questions that ACOG, which is the American College of Obstetricians and Gynecologists, recognizes as being a screening tool to identify someone with a bleeding disorder. So a positive screening result comprises basically that they've had heavy menstrual bleeding since they started having their periods, or they could have one of the following conditions: postpartum hemorrhage, surgery related to bleeding, bleeding associated with dental work. So those are some of the questions that you look into. One of the things that I just recently read about was that there's a new guideline in there. A lot of practitioners look at something that's called Up to Date, which is where we get a lot of our most current regulations and guidelines for practice. and a new guideline that's on the von Willebrand diagnosis. And it's been developed by the American Society of Hematology, the International Society on Thrombosis and Hemostasis, the National Hemophilia Foundation, and the World Federation of Hemophilia. So this is a major change, and y'all may know about this, but this is something that I found interesting. So it's a change where we remove the designation of a low von Willebrand factor for individuals with von Willebrand factor levels between 30 and 50 international units. And instead, those individuals with a personal history of bleeding and von Willebrand factor levels in the range that are diagnosed with von Willebrand disease, 30 to 50%, are considered to have von Willebrand. So there's a change in that diagnosis, which I thought was interesting. Those with, of course, von Willebrand factor less than 30 are diagnosed with von Willebrand factor or von Willebrand's disease, regardless of their bleeding history. So this is just a little bit different. And the use of bleeding assessment tools to determine the need for further testing of low risk individuals is really emphasized in the new guidelines. So this is where you come into practice and you have to use those tools to understand what's going on with diagnosing someone with von Willebrand. So next slide. Oh, I lost, sorry. Oh, okay. So the next slide is differential diagnosis. This is where, whenever I go into a room and have someone that presents, my 70% of people that come in with abnormal uterine bleeding, this is where you often see someone with von Willebrand's disease that has a history of heavy menstrual bleeding. So studies and systematic reviews document that at least, now I've seen different numbers, 10 to 15%, and I also saw 5 to 24%, so a little bit higher, of women presenting with heavy menstrual bleeding have von Willebrand's disease. So now the prevalence of von Willebrand's disease among women is 0.6 to 1.3, but those 0.6 to 1.3 women, of those, they're going to be coming to us for abnormal uterine bleeding. So, and then it also was interesting to see the prevalence among more Caucasian. So it looked at 15.9% versus African American, which was 1.3%. So one of the things that it was a takeaway from me whenever the speaker talked to us about the age and what you're looking for at certain age with diagnosing someone with abnormal uterine bleeding, is that at the end of it, he said, any of these conditions should be considered in the differential diagnosis of all women who were evaluated for heavy menstrual bleeding, regardless of their age, because you may have someone that was put on birth control as a teenager and was never evaluated for bleeding disorders. So it should always be in the back of your mind. What I thought was interesting is that as we start looking at women, and especially women that are diagnosed with von Willebrand disease, how does it affect their overall life? What does it affect for childbirth, postpartum care, contraception? And so I kind of wanted to share some of the things that I've learned about how to take care of these women when they come in with von Willebrand disease. So next slide, please. On the next slide, this was just the different types of von Willebrand disease. So this is an actual slide from Up to Date, which is probably the majority of practitioners in this area. If they come up against a diagnosis or something that they're questioning about and they want to get the latest information on those different rare things that we see in practice, this is where they get their information. So you can see where it breaks it down into type 1, type 2, type 3. And the clinical features of the laboratory findings, and then talks about treatment too. So it's really pretty awesome that this is at the fingertips of most practitioners, that you can pull this information up, and they usually update it pretty routinely. Like I said, that last update was just recently, and they send you an email when they update things, so which I think is very interesting. And next slide, please. So I can't tell for some reason my video, there it goes. Okay. So testing for abnormal uterine bleeding. Some of the things that we talked about in school, and also at this week-long event that I went to, is, and what you'll find on Up to Date, these are what we normally would do for someone that comes in for abnormal uterine bleeding. So pregnancy test, complete blood count, targeted screening for bleeding disorders. So sometimes that may mean that we do some bleeding, like a partial thromboplastin time, a PT, a fibrinogen, bleeding times. And then if that is elevated, or there is some concern, then we would move on to using the vonWillebrand. What we use in our practice is, I use something that's called a vonWillebrand panel, and it has, basically it has a PTT, a factor 8, then the riciticin cofactor assay, and then the vonWillebrand factor antigen. So it has all of that in one panel, so it's real easy to order. You don't have to look around, and you just hit vonWillebrand panel, and that's what comes up. So that's really neat, that there is something that makes it real easy for us to order that. And so I've ordered it several times on some teenagers, and then some older women that have had postpartum hemorrhage and have some unexplained reasons why they're having the bleeding. Next slide, please. So one of the things that whenever I see a woman with von Willebrand disease, we have to look at ways to control her bleeding, which I'm sure that most of you are always looking at ways to control any unnecessary bleeding. So hormonal versus non-hormonal treatment. What I think is very, very interesting is that the 2021 BWD guidelines suggest using either hormonal therapy, which is combined hormonal contraception, or a levonorgestrel releasing intrauterine system, or tranexamic acid over any kind of treatment that we would normally do with a VWD patient. So you really want to control the bleeding from the source, rather than using desmopressin or any of the other things that we would normally, like recombinant factor 8 or VWF complex infusions. You would want to do this, the source of the bleeding. So one of the things that before I left labor and delivery, probably in 2017, might have been 2018, we changed our guidelines for women with postpartum hemorrhage, and we started making it where the nurses had a standing order to start giving some medications that can be life-saving for someone that has a postpartum hemorrhage. And when you see someone that has von Willebrand disorder and they are undiagnosed, that's when you're going to see some of the most significant bleeding happening is during childbirth, because a lot of times these women haven't had surgery, they haven't been hospitalized, they may have had heavy periods, but we've given them birth control and they've done fine, and then they get pregnant, and during their pregnancy, during the pregnancy, your VWF levels typically rise during pregnancy. And then as the at the end of the pregnancy and your estrogen levels fall, then also your VWF factor falls. And so then you have these women that will have a very high chance of having a postpartum hemorrhage. And in fact, I think one of the largest studies reported that the risk of postpartum hemorrhage for women with von Willebrand disease was 50% higher than those for women without a bleeding disorder. So that's huge. And so with these guidelines, the VWD guidelines, they are specifically talking and speaking to those postpartum women and allowing nurses to start treating someone that's in trouble. So these are life-saving measures that we've gotten from guidelines like the VWD. So next slide. I think one of the things that whenever women come in with VWD, the most important thing is preconception counseling. And as you know, the genetic testing may be appropriate for any individual considering childbearing. However, it's rarely used except for individuals with type 3 VWD and some with severe type 2. But it is something that if you have VWD, you might want to mention that you would like to have preconception counseling or even genetic testing. Because of the variability in the different types and recessive versus dominant, genetic passing on, that it becomes a factor in everyone that has VWD and can pass it on to their children. So one of the things that I've learned is that during pregnancy, like I talked about earlier, usually it's well tolerated in women with VWD, and they usually don't require any additional treatment during the pregnancy. We usually measure VWF factor and factor 8 activity levels and platelet count during the second and third trimesters, usually after 34 weeks, because of the thought that the majority of women will end up, most women at this day and age have epidurals. And so you want to look at that being a possibility because someone with VWE has a high risk of epidural spinal hematoma. And a hematoma can cause lifelong paralysis and cause damage to the spinal cord. So that would be a reason why we would want to look at the activity level. And this is the new guideline. I highlighted that in 2021. VWE guidelines suggest women with VWD for whom neuraxial anesthesia, which is basically a spinal or epidural, is deemed suitable. So there's other things that we look at whenever we do a spinal or epidural, which are mainly the platelet count and making sure there's no infections. So there's other reasons why we look at that. But if it's deemed suitable, the panel suggests targeting a VWF activity level of 0.5 to 1.5 IU/ml. So that I thought that was really interesting that we are looking at those reasons to protect mom during labor. The other thing that they have recommended, and this is per ACOG, and this was a paper that I read recently. I think it was, well, I guess it came out in December of 2013, and it's their committee opinion. So the American College of Obstetricians and Gynecologists. And these were the two things that I thought I pulled out of that article, which is that fetal scalp electrodes or fetal scalp sampling are better avoided just because of the risk to the baby, especially if we don't have any genetic testing or have any idea of what baby's risks are. And then also circumcision is another thing to look at. And then I've talked about, or I put on here, operative vaginal deliveries. And those are things like forceps or vacuums because they can have increased risk of trauma, not only to the newborn, with a potential risk of hemorrhage for the baby, but also risk to mother, because when you have those kind of operative deliveries, you can cause trauma in the vaginal tissue, which can cause bleeding. And so those are things that we are mindful of with someone that has VWD. Next slide. So postpartum care, and I think I already talked about this. Yeah. So one of the main things, von Willebrand disease has a 50% higher postpartum hemorrhage rate than women without a bleeding disorder. And so that's where these guidelines that or standing orders come in for nurses to give life-saving medications when someone starts to have hemorrhaging. So the tranexamic acid is one of them. We use Cytotec. We use other medications to help with to help decrease the amount of postpartum bleeding. But if we know about someone that has von Willebrand disease, we can be prepared for that prior to. So that's why diagnosis and recognition is critical for women of childbearing age, because this is where it really impacts them, not only their menstrual cycle, but as they start to have babies, it becomes critical that we know about this because they can have such severe risk factors. This was one that I had heard about, and I didn't know if, and I'm not for sure, for delivery, the patient should be hospitalized in a center where VWF and factor 8 levels can be monitored, and VWF and factor 8 replacement products can be administered if necessary. So I don't know about our hospitals in our area, if that is something that they would provide. I need to find that out. So that will be my next quest, to find out for my patients that have VWD, that they would have that availability at the hospital where they would deliver. And then, which we've already done this, I know at Mercy, I'm sure Baptist has something similar to this, which is our local hospitals. The guidelines suggesting giving tranexamic acid during the postpartum period for all type 1 patients, and then other VWD patients with a low VWF level. So we have those in those standing orders for women after delivery. So that is my presentation. I thank you for plugging along with me. I am excited to talk about this topic just because I feel like from what I understand, we are a little bit behind on recognizing, especially in our young adolescent women, because we tend to not delve into the reasons why they're having the abnormal bleeding. So women of childbearing age is my passion. I've been in women's health for it's been almost 26 years now. Been a nurse practitioner since 2019. And so I'm always excited to learn new things and excited to share what I've learned with everyone. And if anybody has any questions, I'm open to questions.
Okay, I have some questions. Early on in your presentation, you mentioned that there was, to me, the numbers were fairly significant of between different races of how prevalent von Willebrand's disease is. Now, it reminded me of how hemophilia tends to be pretty prevalent among Ashkenazi Jews. And so I wonder what, if you happen to know of any background information that would further shed light on why it's more prevalent, or I would say less prevalent in certain races, von Willebrand's disease, that is.
Yeah, I'm not for sure. I just found that to be so interesting because, you know, I had no idea that those were the numbers as far as with someone that has heavy menstrual bleeding, that we're looking at a higher rate being Caucasian. So yeah, I really haven't looked into the ethnic differences between classes as far as von Willebrand's disease and other bleeding disorders.
I wonder if there's something to it.
Yeah, it's very interesting. Yeah.
Especially when I consider as well that certain strands of hemophilia were prevalent, among the Russians, and the Russian czar, the last Russian czar was pretty famous for that. And then even Queen Elizabeth, it was called the royal disease for a long time. So it's just interesting. If there's any like specific Caucasian group that it manifested in, or has any type of history related to it. Tammy, do you know? Are you there? You're mute.
Mom, you're muted.
No, not necessarily. I have always thought it was very interesting that it started, in like 1929, back with Queen Elizabeth and that family, and Dr. von Willebrand actually, discovered that as going through that family.
Yeah.
So that actually is a great thing that we can all go hunt on Google, can't we? I mean, I joke about that, but honestly, I think these are great reasons why we have these calls, because I am astounded by the numbers. It's just not something that you really think to look at, and then how it will affect different people of ethnic backgrounds. We know that every patient is different, but it would be very interesting to find out if an ethnic background has how they deal with it, or I'm not even sure what I'm trying to say. I do know that I met in women's conferences through the years, I met a lot of from ladies from El Paso, and a lot of their ethnic group were just, so many of them did have a bleeding disorder, whether it was hemophilia or VWD, and it was so much harder for them because of their ethnic background, and talking about it and feeling comfortable telling a doctor this is happening. And so I learned a lot, from them, just on how they were affected. So that is a very interesting thing to look at.
Thalassemia and sickle cell disease are fairly prevalent among Middle Easterns, for example, as well. And so I'm just curious, because those numbers that you represented in your presentation, higher Caucasian, lower African American, that rings pretty true for Oklahoma, at least our demographic.
Yep.
I can't, in fact, it might be even less. But yeah, I can't think. Whereas hemophilia seems to be more prevalent in some other groups. Anyway, that's just something I kind of pulled out.
Tammy kind of hits on a point that's interesting, because you think about how these patients present and what their presenting symptoms are, and how their culture and their ethnicity plays into what they're willing to divulge to their doctor or to their provider, and where you catch them in the treatment or where you catch them in the diagnosis. Is it because that these women that may suffer in silence because that's their culture, or that's, something that in their culture is considered normal? And so that's interesting to think about it that way too.
It's funny you said the word normal, because we had, sorry, I'm into it.
You go, girl.
I think you're going to say what I'm thinking too, Tammy, is we had our, a newer hematologist present at our annual meeting. She spoke about women and von Willebrand's disease, and talking about how generations of families have this idea of what's normal. So they don't know that it's abnormal what's happening. So culturally, of course, that could happen. Especially within an ethnic group. If everyone thinks it's normal, then no one would say it's abnormal, and would consider getting help or tested,
Right. And a lot of times, one of the things that we talked about, the screening process, one woman may think that if you change your tampon every hour, that's normal, whereas another woman knows that that's not normal.
Right.
And so there is that difference. We even have, I have a visual screening card that you could hand somebody so that they can look at how much is on a pad, how much is on a tampon, how often you're changing it, because sometimes, like you said, the family has potentiated that this is a normal process when it's not necessarily normal.
Yeah, I had no idea. I was abnormal because
Yeah.
my mom thought it was normal, and
Yeah.
so on and so on and so on.
We're definitely in that same bracket because, of course, when I was a child, I started my cycle at 8. And so I was very young. And at my home, you did not talk about that. That's just not something you talked about. And so I was one of the women that suffered in silence because I had no idea what was happening. And yeah, there again, my gynecologist kept saying, that's normal. That's normal. Just put your feet up. And I just kept thinking to myself, is this really normal? And then up until I was diagnosed, or a few years after, I found out that my grandmother and my great grandmother had bled really bad. And my mom had issues, but was in total denial of that. And I also loved when you talked about, the new things that you're looking at instead of going straight to hysterectomies, because I was one of those that I had just bled so bad. And the first year when my OB said something about it, I'm like, nope, not ready for that. Can't say I don't want any more children, but I can't say, or that I do, but I can't say that I don't. And I was raised in the background where when you lose your female organs, you are no longer a woman. I mean, that was the mindset then. So I'm glad that that's changing, because there are so many that just jump right to hysterectomy. Now, the second year I went back, the bleeding had gotten so desperate that I couldn't leave home. It was just one of those things. The pain was so intense. So that was kind of what brought me to that. And, I was in my mid-30s. And then when I look back now, I had a great, I don't have any complaints. However, he was from England. So it really kind of surprised me that he didn't know anything about bleeding disorders.
Right.
But let me just say that we did teach him about bleeding disorders, and he managed to take care of us for many years until recently. So, and he is since, I think, retired. He's not delivering babies anymore, but that's a big thing too. I just really want to encourage those of you that are on this call, do not just assume. If you continue to feel that there's something going on in your body that does not feel right and does not seem right, don't just ignore it and say, well, everybody in my family did this, because that means that everybody in your family probably had the same issue. So that's very important. And I am so amazed that Liz has shared with us tonight about how they're looking at that differently, because if we can continue to get our OB care teams on that same mindset, look at all the women that and teenagers that are going to have life-changing experiences. And I never even thought about, I didn't have, I had all my children what they would call natural childbirth, but I never even thought about the hematoma setting up. That never entered my mind until now. So that definitely is something else that we need to add whenever we're teaching and sharing, is that use a lot of caution there.
I have to say, I want to chime in on this epidural thing, because I don't have Willebrand disease, by the way. I have a different rare bleeding disorder, but we have similar symptoms and issues. So the epidural thing stuck out to me because the first time around during my childbirth, I did not have a treatment plan in place correlating with my hematologist. Let's just say I was not diligent about it. Well, anyway, the second time around, lesson learned, right? And so because it was flagged in my notes, the anesthesiologist would not give me an epidural until my clot time came back. And although I was angry at the moment because I was I was thankful later, because I didn't realize that this was a risk until he told me about it later. And I just didn't know that. I should have known. A big old needle going into your spine, surely there's a risk there. But specifically for a subdermal hemorrhage hematoma type thing, that could be detrimental to me. I was thankful that he intervened, even though it, it hurt.
Yeah.
Anyway.
Well, what's nice is that if we know ahead of time, we can start, like I said, in that third trimester where we start making those plans and maybe even involve anesthesia. I know, you know, when I worked at Mercy as a labor and delivery nurse, we would call in anesthesia, and if we had a difficult case, just to get them started, even though they weren't in labor yet, but at least get them in on looking at, is this somebody that potentially needs some further blood work or some lab work like you talked about. They would look at the platelet function, testing to make sure that this person would be safe for having an epidural or a spinal. And most of the time, most women are going to be safe, but it just takes that just a little bit extra test or step just to make sure, and an expert in that area. So with the hematologist and anesthesia in on the team makes it a lot easier than just your obstetrician looking at it.
Absolutely.
Yes, it is. Gabrielle?
So I want to chime in because I was one of those early hysterectomy people that by the time I got to Liz, I was like, all the doctors have told me I need a hysterectomy. She's like, no, we're not going to do that. So I am glad that she went a different direction because I'm a little too young to have one. Even though some days I'm like, I want to rip these things out. I'm done. But I do have a question, and I'm a weird one. Everybody's gonna think I'm weird, but I want to have a home birth. So how would you encourage somebody with vonWillebrand that wants to have a home birth to prepare?
I think, you know, I would still be vigilant in getting prenatal care. And like I talked about in looking at your VWF levels, like I said, right, it's not necessarily the birth itself that's going to be the issue. It's that postpartum hemorrhage. And that's where things can get, I mean, postpartum hemorrhage is not, when I've seen someone go into or have a postpartum hemorrhage, it's not a normal, it is someone that deteriorates very quickly. And so it's not so much the home birth that because I'm like, I had a midwife and I delivered in the water. So I love midwifery and I love home births. I think where I would worry would be in the postpartum. And that's where that, you know, that guideline talks about tranexamic acid, having that available after delivery, you know, being close to a facility where if you started to have, you know, a postpartum hemorrhage, that you could be taken care of immediately. So, you know, a lot of times, when I think about home births, I think about those are very, very low risk patients that have the lowest risk. When you're looking at someone with VWD, that may not be a person that's low risk. So, you know, I risked out, like even with my last pregnancy, when I had a midwife with my fourth pregnancy, I risked out because I'd had a previous C-section. So you really have to look at, and I was so disappointed because I had to go to the hospital and deliver. I was beside myself. Kind of like Jeanette was saying about the epidural. It's kind of like you're angry because that's not your plan and that's not what you want. But you have to look at the risks versus the benefits. And so I think you could do a low intervention birth, but not be at a risk of being at a home birth with the risk that you have as far as having von Willebrand disease. Does that make sense, Gabby?
Mm-hmm.
I mean, I don't want to ever discourage somebody from, because I'm all about natural, but I think you have to look at each thing. And sometimes your risk outweighs the benefit of doing some of those things.
So basically what I'm hearing you say is we just need to find somebody to open up a birthing center in Portsmouth.
Yeah, yeah, yeah. Birthing center would be key. Yeah, it'd be awesome. And what's funny is I had my third child was at a birthing center. And so we had one back in 1997. That's how long ago my child was born. And it was at a freestanding birthing center. She was delivered in the water, but we also had the capability to start an IV or to give meds. And we had a nurse there. And so there was some things that were just a little bit step up from a home delivery. So that, and that may be in the future, I don't know. Northwest Arkansas, I know, had some midwives, and they did have a birthing center. I don't know if it's still open at this point. Last I heard, COVID kind of hit it hard, but that was the last I heard.
I have to echo what Miranda has said in this chat, because you have no idea what complications your baby might have. If they, as you know, it's a 50-50 shot for every kid you have,
right?
Gender aside with vonWillebrand. So I've certainly have seen in our community that if the parent might be mild, but the child might be severe, we have a type 3 in the community. That's super rare. It takes, both parents have to have it to be able to pass it on, or a type to pass it on. So you just never know. And neither of those parents knew that they had it. So should you find your partner for life and maybe they don't know, so I definitely echo what Miranda's saying. We consider that the baby might need some intervention.
Me and Aaron had no idea also, and Theo has vonWillebrands and hemophilia.
Oh, bless him.
So yeah, one from each. But I have a question. Whenever you get like a clot in your lung, what is that called? And you could die from it?
APE. Pulmonary embolism.
Could you get that like after you're taking like your aftercare treatment? Is it more common for affected people?
That's a good question. I'm not for sure if there is a increased risk of a pulmonary embolism. Are you asking with von Willebrand disease?
I personally have hemophilia, but yeah, it'd kind of be the same treatment. Kind of.
Yeah. Not that I'm aware of, but I haven't done the research to look and see if there is an increased risk of getting a pulmonary embolism.
Okay.
I'm also not a doctor, but I will say that there have been cases of overclotting when mixing medications. I can't and won't say which, but that has happened and resulted in fatalities and certainly problems. So certainly check with your hematologist. If you're having any kind of surgery or operation or incident, make sure that they are aware so that your medications, all your medications in combination can be considered for safety reasons. That's all I have to say. Again, I'm not a doctor, but I just know that our history our bleeding disorder history proves that that's an issue. So be aware.
Yes, it can be an issue. I was one of those that had severe postpartum depression, severe postpartum bleeding. And of course, there again, I was not diagnosed at the time. I just couldn't understand, back whenever I was giving birth, it's like, oh, if you breastfeed, you won't have a cycle anymore. Well, I never stopped bleeding from after birth until I go to my 6-week checkup, and I'm like, okay, why am I still bleeding? He's like, oh, some moms just do that. Now, I love this doctor. He was great. But there again, it just lets me know, I think whenever I start on the advocacy side, is that we have to advocate way stronger than ever before, because we're at a time now where that care is so demanded and so needed. Not that it wasn't then, it's just that so many more people now are coming to know about different types of bleeding disorders. And we just don't want it ignored. And I think that that's a big thing. But I never stopped bleeding, straight on through, started my cycles back. And then with Gabrielle, she was about 3 weeks old, and I stood up and blood went everywhere. Scared me half to death. I just screamed, and my husband was outside. Evidently it was bad enough. He heard it and came running in, and I'm standing on the living room floor and blood's just going everywhere. So he helped me to the shower, call my OB, and guess what he said? That's normal for some moms. Just have her put her feet up. And so I go back to that. And when I hear that's normal, I guess I just sometimes cringe on that, because no. And I mean, even at that point, I thought this can't be normal. But at the same time, I didn't know anything different. So I'm so glad we're having these open conversations, and we're encouraging, ask those questions. They're very important. So we've got about 4 minutes left. I'm going to let you take it from here, Jeanette, and just kind of do what you need to close us out. And if there's any
Sure.
more questions or comments.
Well, certainly if there are any more questions, now's the time. We have our lovely Liz with us. Thank you. I can't thank you enough. This has been really wonderful. I can't wait to share it with our community and let many people hear this information. I think it's so valuable, and we appreciate your time and especially your effort in preparing all of this information for us. Thank you so very much.
I got one more question.
Go, Miranda.
Okay. So endometriosis is common with bleeding disorders, right? Kind of. They intertwine.
There is some information out there that that you do see endometriosis and other things with bleeding disorders. Yes. Sometimes endometriosis can look like an autoimmune too.
So where I'm going with this is, like, I read somewhere that it could like go in different parts of your body and maybe even your lung. In your time of working, have you ever had one of your people with endometriosis spread so far? Or
So since I don't do surgery now, usually endometriosis, you treat that clinically. So you diagnose that clinically. The only true way to diagnose it is to take someone to surgery and do biopsies. And there are women, because endometriosis is staged. It's kind of got a mild, moderate, severe, but it's staged. And there are women that have severe endometriosis, and the endometriosis is basically, what I think of it is the endometrium, which is the lining of the uterus, kind of attaches to all different areas, and it can become very severe. Most of the time I see patients that are early stages of endometriosis, or in a stage 1 or 2 or 3. Someone that's really severe is usually sent out for a referral. And since I don't do surgery, I don't see the endometriosis in the person's body. So I can't say that I've seen that. But there are women that do struggle with endometriosis, and it can be found at weird locations where you shouldn't have the lining of the uterus. So,
so whenever you said, what'd you say? You said that, sorry, my son just distracted me big time. Oh, I have stage 2. And that was in 2016. But I don't know where I was going with that. I'm so sorry.
you're fine.
You said something important.
Well, one of the things about endometriosis is if you can control and you have those lesions that can be controlled with birth control, can be controlled with hormones and other medications. It allows the body to heal itself. So sometimes if you've had surgery and those lesions have been removed, they can actually get better and may not get progress or get worse as long as you're staying on treatment. Does that make
Yeah.
sense? So
Yeah, right
you can
now I'm on
manage it.
Orlosa,
Yeah.
and it seems to be helping quite a bit. I remember now. You said that it sometimes acts like an autoimmune.
Mhm.
What is that? Like, why do you say that?
There's lots of thoughts about why, or talking about endometriosis. There's lots of thoughts of how it happens and why we see it. There's not a theory, a specific theory, on how endometriosis happens. So there's lots of theories out there of why it happens and how it happens. So
Okay. Okay. That's all I got. Thank you.
you're welcome.
Great questions, of course. Well, we are hitting the 8 o'clock mark, so I just want to be respectful of time, especially your time, Liz. But if there are any more questions, speak now. If not, we will thank you so much for your time. My goodness, this has been great.
It has been really good. Thank you so much, Liz.
Yeah, you're welcome. Well, it was great talking to everybody, and hopefully we can make a difference in women's lives, and definitely look at rare disorders and not see them as rare as and normalizing things that seem to us that are abnormal, normalizing them so that cultures don't think, oh, this was normal, this happened to my mother, why is this happening? We need to ask why is this happening to me? And just standing up for yourself and understanding that you know your body best and you know what's normal for you. So no one else can tell you what's normal. You know what's normal for you. So
that's right. Well, thank you again. And I appreciate your willingness to let us put this on YouTube so other people could be blessed by it. Thank you so much.
well, y'all have a wonderful night.
Good night.
Thank you. Y'all have a great night. Thursday, there's another community connection on Thursday. So be sure to join that one. It's all about school and how to consider your bleeding disorder at school. So we'll see you on Thursday.
Awesome. Thank you.
Bye.